बैठे तुम लोग, खड़े क्यों हो? यहाँ तो चलेगा नहीं क्लास, तो ये बच्चे कैसे सुनेंगे? इनको
मोबाइल पे।
अच्छा, तो तुम लोग भी जाके मोबाइल पे सुन लो, तो यहाँ तो डिस्टर्बेंस नहीं होगी इनको, नहीं होएगी ना? अच्छा ठीक है। एनीमिया, हाँ। बता देना आप कब स्टार्ट करना है। ये चेयर वेयर सब साफ होती हैं थोड़ा यहाँ, है ना? तो इसमें नहीं दिखेगा जो आपने लिंक विंक बनाया है, वो अपने आप जाएगा
हाँ,
उनको?
स्टूडेंट के पास अपना।
अच्छा, इस सरल पे चल रहा है क्या?
हाँ।
अच्छा, उनको स्लाइड दिखेंगी। और अगर टू वे कम्युनिकेट करना है तो, अगर उनसे बात करनी है, वो लोग क्वेश्चन पूछते हैं तो?
वो क्वेश्चन पे लिख के पूछते हैं।
अच्छा, और डिस्कशन नहीं होता है, वो बोल नहीं सकते हैं वो? अच्छा, तो ये बच्चे वहाँ क्यों बैठे हैं? उनको भी यहीं बिठा लेती हूँ मैं, तुम भी यहीं आ जाओ फिर, तुम वहाँ क्यों बैठे हो? तो आप बताओगे स्टार्ट करना है क्या? अब ऐसे पता कैसे चलेगा कि वो लोग है नहीं है, क्या है? कुछ नहीं, ऐसे ही बस बोलना है। गुड मॉर्निंग। अच्छा, कितने स्टूडेंट्स हैं?
जाएंगे सुबह वाले में तो 14 थे।
14? तो आप वहीं से देख के मुझे बता देना, ठीक है? अब ये हमारे पीजी, मेरी बात फिर आप सीरियसली बताओ, इनको यहाँ बुलाने का फ़ायदा है क्या बच्चों को?
नहीं, ये तो अपना फ़ोन पे जो लिंक मैंने इनको तीनों के पास है सर।
अच्छा, इनके पास है, तो ये अपनी स्क्रीन पे बैठ जाएंगे?
हाँ, यहाँ पे भी,
अच्छा।
यहाँ पे देख सकते हैं ना।
हाँ। ठीक है, यू कैन ऑल्सो गो एंड सिट देयर। आई थिंक यू ओपन अप योर फोन्स बिकॉज दे आर नॉट, आई थिंक, स्टार्टिंग दिस। ये प्रोजेक्टर नहीं लगेगा ना?
नहीं, अभी चालू है, अभी आपका।
अच्छा, good morning everyone. Should I start? So we'll discuss this topic of anemia in pregnancy, and basically mainly we will discuss the nutritional anemia in pregnancy because the prevalence in our country is very high. So we will discuss under these topics of definition, what is the burden of anemia in our country, what are the classifications, consequences of anemia, and then mainly we will discuss the two main anemias, iron deficiency anemia and megaloblastic, which are the main two types of nutritional anemias. And then we will discuss what are the national programs which have been devised to tackle these problems. So what is the definition? This by WHO, it describes when the hemoglobin is less than 11 gram per deciliter. This is the standard definition, and in the CDC they have defined that because of dilutional anemia in pregnancy, in the second trimester we take cutoff of 10.5, and in first and third trimester the cutoff is 11 gram per deciliter. So why it is important because anemia is only the tip of the disease, but overall we see the iron deficiency is a big prevalent problem. So it is like the iceberg effect. We only see the patient when they come to us with hemoglobin less than 11, but actually the problem is much wider and much broad than we see clinically by just measuring the hemoglobin. So that is why we need to address the problem of iron deficiency also in addition to anemia. So anemia is the most common medical disorder in pregnancy, and in the WHO it has been seen that almost 40% of pregnant women worldwide are anemic, and in South Asian countries, which are the main this prevalence of anemia is there, and 50% of global maternal deaths happen due to anemia in the South Asian countries. And of these maternal deaths, India contributes to almost 80% of maternal deaths in the South Asia due to anemia. So how we calculate the prevalence of anemia? Like we have this national family health surveys which happen every 10 yearly, and like if we compare, the last was NFHS 4 which happened in 2015 and 16. If we compare over a period of 10 years, you can see that there is mild reduction in the prevalence of anemia in pregnant women, but still the 50% of all pregnant women in India are suffering from anemia. And in the breastfeeding population also, the prevalence of anemia has been calculated almost 58%. So this is a broadly, you can see anemia, see in our country, if we see the pregnant women and lactating women, most of the states in our country, they have prevalence of anemia more than 40%. So that is why it is important to address the issue and to manage this problem. So why India belongs to high prevalence? These are various reasons, because of poor eating habits, our own traditional food habits, then early onset childbearing due to early marriage, then high parity, short interconceptional period, lack of accessible healthcare facilities, which is like almost 50% of pregnant women, they don't even reach the healthcare facilities to get the proper treatment and in time. And then high prevalence of H. pylori and hookworm manifestations, malaria, deficiency of iron in soil, and in some states there are hemoglobinopathies which are common. So when we have to classify the anemia, we have to see how much the severity of anemia, what is the cause of anemia, what is the type of anemia. If we are able to address these three points, then only we will manage our patients. So what is the severity of anemia? This WHO defines anemia, it has three stages. Like as we discussed, the cutoff is 11. Any woman who has hemoglobin less than 11, we label that woman has to have anemia. So we have mild, moderate and severe. 10 to 10.9 is mild, 7 to 9.9 is moderate, and if the hemoglobin is less than 7, this is categorized as severe anemia. So in addition, ICMR, because we have discussed that our country falls in the with high prevalence of anemia. So we even encounter women who have hemoglobin less than 4 also. So that is a critical situation. Otherwise the classification is same. So we have added one more classification. If the anemia hemoglobin is less than 4, then patient is classified to have very severe or critical anemia. So once we have defined that how much is the severity, then we have to know what are the types of anemia. So types may be either acquired or inherited. In acquired, we have most commonly this iron deficiency anemia, which may be because of iron or deficiency of B12 and folic acid. And then we have hemorrhagic anemia because of blood loss, which may be acute or chronic. And then some patients, they suffer from chronic diseases like liver or renal diseases, which may be the cause of anemia. And then we have aplastic anemia. Inherited, most important which we encounter are thalassemias, because beta thalassemia trait they present with mild to moderate anemia. And then we have sickle cell disease, hemoglobinopathies and inherited hemolytic anemias. So those are the types. Now we have to classify what type of anemia patient is suffering from. According to this, the most important parameter we actually need to calculate the red cell indices. According to the mean corpuscular volume, we see whether the patient has on the peripheral smear microcytic picture, normocytic or macrocytic. In the microcytic, if the MCV is less than 80, then the most common cause is iron deficiency anemia, and the most important which we have to differentiate while we are treating our patient is thalassemias. And then we have anemia of chronic disease and sideroblastic anemia, and some this lead poisoning and copper deficiency. Then we have the normocytic anemia, where the picture is normal, normocytic, normochromic. So here the most common is the like anemia of chronic disease. But if the patient is presenting with normocytic, she may have even early iron deficiency anemia also. And then other causes like because of blood loss or hereditary spherocytosis, these diseases they overlap. Like in the early stages they present with normocytic, and then ultimately they become microcytic. In the macrocytic, when the volume is more than 100, then the most common cause which we have to treat and the easy to treat and we encounter is the folic acid and vitamin B12 deficiency. And then we have other less common causes. So what are the causes of anemia? See, all these points are important, because only then we will be able to treat the disease, when we have known what is the cause of anemia, which may be because of blood loss, because of excessive cell destruction which happens in thalassemias and sickle cell anemias and hereditary spherocytosis, or there is red cell production, because here this is the most important cause which we have to understand is the nutritional deficiencies, which are mainly these 3 iron, folic acid, B12 deficiencies. So what happens, the physiological changes in pregnancy, if we see that the volume, plasma volume and blood volume increases almost by 40 to 50%, but the proportional RBC mass increases only by 20 to 30%, which is the cause of physiological or dilutional anemia in pregnancy. But this is not a pathological disease, it returns back to normal within 6 weeks postpartum, and we take the cutoff which we have discussed like 11 and 10.5, and this is usually normocytic, normochromic. So why it happens? Because this is a physiological adaptation of the pregnancy of the body, because decreased blood viscosity is important to increase the placental perfusion, so that increase the fetal oxygenation. So this is a protective buffer against blood loss in 3rd stage. So it is the body adapts itself to tackle the blood loss in the after the delivery of the baby. And then coming to what are the consequences of anemia in pregnancy. So why we are addressing these causes and types of anemia? Because if the patient is suffering from anemia, she will have more chances of preterm birth, preterm rupture of membranes, hypertension. Because of because of anemia, she will end up in congestive cardiac failure, more risk of antepartum hemorrhage, and she is at more risk of infections. Then in intrapartum period, she is at risk of abruption, fetal distress, prolonged labor, and increased risk of operative vaginal delivery. And again, this is very important, like she may have congestive cardiac failure in the intrapartum period also. And these patients are more at risk of postpartum hemorrhage, sepsis, lactation failure, subinvolution of the uterus, postpartum blues and depression, and pulmonary thromboembolism. And the baby, if the mother is nutritionally deprived, she has anemia, she will have definitely the babies with low birth weight, prematurity, and increased risk of infections, and maybe may also have neonatal anemia. And severe anemia, especially in our country and other South Asian countries, has been reported to have increased the chances of postpartum death also. So this is the reason, to control the perinatal morbidity and mortality also, we need to treat this anemia. So we will mainly discuss the nutritional anemia, which happens due to imbalance between demand and supply of micronutrients which are required for erythropoiesis, and these 3 types we will discuss. So why it happens? It is either because of reduced intake, because of dietary deficiencies or bad food habits, or it is because of reduced absorption because of dietary factors. And patients who had undergone bariatric surgeries, they suffer from malabsorption syndromes for almost up to 12 to 24 months. So then if there is increased demand, like in pregnancy and lactation, impaired utilization, because if we are just loading the patient with iron but we are not giving her folic acid, or patient is on some drugs which act as folate antagonists, so that may also cause anemia. Then if it is because of excessive loss, like patient has antepartum hemorrhage, or she has some chronic renal disease causing chronic blood loss. So iron deficiency anemia, this is the most common nutritional deficiency. As we have understood, pregnancy is a state of negative iron balance, and only 10 to 15% of total iron is absorbed. So if we see the prevalence of anemia is only the last or late indicator of iron deficiency. If we see the prevalence of iron deficiency per se, it is almost 2 to 3 times more than the prevalence of anemia, which we calculate in our studies. So actually we have to see what is the prevalence of iron deficiency, and we have to treat the iron deficiency if we want to combat this problem of anemia. So what happens in pregnancy physiologically? Because excessive iron is required, the absorption is just 10 to 15%, and the requirement of iron is increased in pregnancy. So if we see broadly in a normal weight woman of 55 kg, the iron is required for fetus and placenta, which is around 360 milligram, expansion of red cell mass, obligatory losses from the body, and blood loss during delivery. If we calculate all these iron requirements, the amount is around 1000 milligram. And if like we consider if she has 9 plus 6 months amenorrhea, so this much this iron is saved. So roughly net iron requirement in a patient with normal weight during pregnancy and lactation is around 700 to 800 milligrams. So we need to replace this iron during pregnancy and postpartum period. So again, this is one important issue, like when we are prescribing patients oral iron tablets, and we will discuss later on, like there is problem of this compliance, because most of the patients, they have side effects. So we need to understand how iron is absorbed into the blood. So what are the steps, like either patient is taking heme iron or non-heme iron. So there are factors, like these are important things when we counsel the patient, that they should not take the tablets with milk or calcium phytates or phosphates, these type of things. And there are vitamin C and ascorbic acid, they increase the absorption. Like if they are taking a tablet with milk, then absorption will not happen. So when it is from the food, it goes to the intestine, it is absorbed in the ferrous form. So when then it goes from the intestine to the blood, like it is going to plasma, it is again converted into ferric. So the more iron is going into the blood, there is system that liver produces this hepcidin. So hepcidin is the control, or we can say that this is a checkpoint which controls iron absorption. If we see in a 24-hour, like patient has taken one iron tablet and it has gone in the ferrous form, and then it is being converted into ferric form. So hepcidin will be formed and it will block this ferroportin, this transporter. So the absorption of iron for next 12 to 24 hours will be blocked. So this is a control system, because beyond a point we cannot just give that patient to treat anemia, like we are giving 2 tablets or 3 tablets. So there is a control system. This is the reason when we give more tablets, like 2 tablets or 3 tablets, so the absorption does not happen. It only causes side effects, because that iron is just then entrapped into the intestine and it is not transported into the blood. So hepcidin is now being considered as a marker to understand iron deficiency also, and to better understand how iron is absorbed into the blood. So this is a diurnal variation which people have studied, and it is just to tell you that hepcidin is again a important marker which is being studied as a biomarker of iron deficiency anemia. Because when like in the same picture, if the iron is not coming from the food, intestine is not providing any iron to get transported into the blood, so definitely the hepcidin level will be low. So hepcidin is being considered as a latest marker, diagnostic marker of iron deficiency anemia, which tells us that the supply of iron is insufficient. So that was just new. Now we are coming to evaluation of anemia. We have discussed the prevalence, the causes, the etiology. Now if a patient has come to us, like how we are going to evaluate and manage the patient. History is very important in this patient. Then we have to see signs and symptoms examination, and then investigation, so that we can manage the patient according to the cause. So any patient, pregnant or non-pregnant, she is coming to us, we have to understand what is the cause and severity of anemia. Any history of bleeding per vaginum, passage of worms in the stool, jaundice, easy bruisability because she may have some underlying blood disorders. Then any history of hematuria, bleeding per rector, or bleeding from any site of the body. Any history of chronic illness, whether she has taken iron folic acid tablets or not. Any history suggestive of cardiac failure, like if she is severely anemic, she may give you history of breathlessness, pedal edema, palpitations, or any history of pica. Then we have menstrual history. We have to ask in detail what are the frequency of their cycles, regularity and flow, because a patient who is suffering from chronically heavy menstrual bleeding may be a cause of chronic anemia, so we need to address this issue. Then in her OBS history, we have to understand what is her parity, what was her age at first pregnancy, and whether she has had proper interpregnancy interval also, because we have to see that short interconceptional period is again one important cause, and if there is any history of postpartum hemorrhage in previous pregnancy. We have to rule out chronic medical or surgical illnesses, and any history of bleeding disorders, history of recurrent UTI, because recurrent UTI again is a cause that she may have renal type of anemia. and any history of excessive blood loss and requiring blood transfusions. Any history of hemoglobinopathy, because thalassemia and all those hemoglobinopathy, sometimes they have family histories also. And then what is a dietary history? Dietary history is very important in these patients because they may suffer from chronic nutritional deficiencies in addition to iron and folic acid, and we have to rule out if she is suffering from some malabsorption syndrome and this socioeconomic status, because in our country we understand that those patients who are not from low socioeconomic status, they don't even get chance to visit the healthcare facility even once or twice in her whole pregnancy. So this is very important because this addresses how much and what type of diet she is taking. So after the history, we have to see the clinical symptoms and signs. We have to see symptoms, like we will ask these important things which we have seen in the history, and signs we have to look for pallor, glossitis, squalonychia, tachycardia, pedal edema and physiological murmur also, so which may be the signs of anemia. So then coming to investigations, so we have discussed all these things, so now we have to first we will see how severe is anemia, what is the type of anemia, what is the assessment of, we will see the iron stores, because iron stores again we have discussed that we need to treat the iron deficiency also. So then there are some new this advanced test which we see the assessment of heme iron and iron absorption, which we do not do routinely. So first is severity of anemia. We have to go by simplest method and minimum investigations, because we cannot tell each and every patient to go for all investigation. So the most important investigation to assess severity of disease is just simple complete blood count with hemoglobin estimation, which can tell us that whether she is anemic or not. So all antenatal patients who are coming to us at the first antenatal visit, this is very important. And then we have to see if the hemoglobin is less than 11, then the simplest test is just get one RBC indices and peripheral smear, which will tell us that what type of anemia she is suffering from. And as we have discussed that iron deficiency anemia is the most common, which we have to differentiate from other microcytic hyperchromic anemias. So we will get one HPLC done to confirm the diagnosis. And then we have this red cell width. Red cell width is what? Actually what happens in the iron deficiency anemia, if you can see in this picture, there are different types of cells. Basically this is because of anisocyclopoikilocytosis. So what happens in the iron deficiency anemia, there are different sizes of RBCs as compared to thalassemias, where they have the synthesis has stopped at a particular stage, so all the RBCs will be of same size. So because of this, increased red cell width tells us variance in the RBS volume, which tells us that it is increased in iron deficiency anemia, and if it is less than 13 or less than 14, then we say it is because it is thalassemia. So RDW is basically to differentiate between thalassemia and iron deficiency anemia. So so these are the main causes of microcytic hypochromic anemia, where picture in the peripheral smear will be same, and how you will differentiate. One is RDW width, then serum iron will be low, which will be normal to high in thalassemia because there is no iron deficiency. So these are the important 3-4 investigations which we are routinely get done to confirm the diagnosis of iron deficiency anemia, because when we are treating the iron, we don't want patient to overload with iron. So total iron binding capacity will be increased in iron deficiency anemia, saturation will be less, ferritin will be less than 15, which is usually high because thalassemia patient, they do not suffer from low iron stores. So, and the hemoglobin pattern will be abnormal in thalassemia. So these are the important 3-4 tests which are required, and thalassemia is definitely more common than sideroblastic anemia. So these are the two types which we need to differentiate. So this also you can just remember, in iron deficiency anemia all the things are low, just RDW is high, and in thalassemia all these parameters are low, hemoglobin is low, MCV, MCH is low, but because the hemoglobin this concentration is normal and RBC count will be high because there is no destruction happening, and here the RDW will be normal. So these are just to remember between these two types of anemia. So then comes, like we have seen as we discussed, that we need to address the problem of this assessment of iron stores also, because patients are usually less having less iron stores, even if their hemoglobin is 11, she may suffer from iron deficiency. So for that we have serum iron, serum ferritin, and percentage transfer saturation, and TIBC. These are the 4 tests which are easily available and we get done to understand the iron stores. And there are some advanced tests also which we do only in research setting. So serum ferritin, we get it done all the patients with iron deficiency anemia, but again it is acute phase reactant, so sometimes it comes false positive. So then we have to see the other investigations, other test of iron stores. So these are the tests we can see. MCV we have discussed will be reduced in iron deficiency anemia. RDW will be increased, it will be more than 14. Ferritin will be less than 15. Iron will be less. TIBC will be increased. Saturation will be less than 15. So these are the tests which we get done. There are advanced tests which we not do routinely. So then another thing is Menzer index. What is this? It is basically, as we have discussed, the RBC count is decreased in iron deficiency anemia, which is normal or high in thalassemia. So this is a quotient of MCV which is divided by RBC count. So the value will be less than 13, then the likely diagnosis is thalassemia, and if it is more than 13, so it is likely possibility is iron deficiency anemia. So these are the indices which help us to differentiate between these two types. So these are done only for research setting. We are not doing these tests done routinely. Just to have you just about a word that it is assessment of iron absorption. We get the soluble transferrin receptor levels done, and then it helps whether the iron is going to tissues or not. So then comes what is the role of bone marrow aspiration? Routinely for diagnosis of iron deficiency anemia, definitely it is a gold standard test, but it is not done routinely. It is only in some patient if we are not able to diagnose what is the exact cause of anemia, and if the patient is not responding to any of your therapy, and she is presenting, in addition to anemia, she is presenting with hypoplastic or aplastic anemia, then we have to confirm with bone marrow biopsy, or in patients with their areas where there is prevalence of Kala-Azar. So this is again one important table, like what happens, what are the stages of iron deficiency anemia. Like if there are 3 stages, like if we see the normal, that everything is normal, initially there is negative iron balance, like the stores have started depleting, but there is no evidence of anemia on the peripheral picture or in the volumes. Then comes the iron deficient erythropoiesis, when the RBC indices have started being affected. So finally patient lands up in iron deficiency anemia when the hemoglobin comes less than 11 and the patient presents with a picture of a microcytic hypochromic anemia. So these are the 3 stages of iron deficiency anemia, and which we need to treat or address when we are managing these patients. So if we are sitting on a peripheral health center where all these tests, advanced tests are not available, so what minimum test we can get done to treat the patient? So we just have to order one complete blood count, peripheral smear and HPLC, because mainly we need to rule out the thalassemia. So these simple 3 tests are sufficient to diagnose a patient of iron deficiency anemia and to rule out thalassemia. So now coming to treatment, what are the treatment options we have to, this dietary measures we have to tell to the patients. Deworming is very important in our country, iron supplementation, and what are the indications of blood transfusion, these we will discuss. So it is very important to counsel the patient, to tell them what are the iron rich foods like jaggery, all this green vegetables, pulses, and then we have to, we can tell them that they can cook food in iron utensils. They have to, this is the most important, that when they are taking iron supplements they should not take with milk or tea, and we can add vitamin C or ascorbic acid to increase absorption of iron from the diet. And we have to tell them that the iron tablets should not be taken in with the meals, which will again decrease the absorption. And then food fortification is also being done to increase the supply of iron along with the foods. So in our country, this is the latest program which is being which was started in 2019, this Anemia Mukt Bharat by Government of India, where all health facility based programs where food is basically being provided to all the these patients, so that fortification of food is done with iron, folic acid and B12. So all this so that we can provide micronutrients to these patients who have high prevalence of anemia and iron deficiency. So what is the recommendation for deworming? In our country it is recommended that all women after first trimester they should be given albendazole single tablet 400 milligram, because it doesn't have any side effects and it will treat all the patients who may have additional hookworm infection. So WHO also recommends that, as we have discussed, our country falls in the prevalence of more than 40%. So hookworm, this WHO tells that any area or any country where the prevalence is more than 20%, there all the antenatal women should be given albendazole 400 milligram after first trimester, and if the prevalence is more than 50%, then sometimes we need to repeat also treatment after 3 months. So what we are following, we are any patient in our setting, because ours is a tertiary care hospital, so all patients who are suffering from anemia, we give them one tablet of albendazole 400 milligram. So then coming to iron supplementation, how we have to treat the patient for prophylaxis treatment, and what is the recommendation in postpartum period. Our country, it is if we see the WHO recommendation, because WHO, what is, it is for the all the countries worldwide, because iron deficiency, it is not that prevalent as compared to our country or South Asian countries. So they recommend that dose may vary between 30 to 60 milligram of elemental iron per day, depending upon the prevalence of anemia in a particular country. So if we see our country, because as we have discussed that we fall in more than 40% of prevalence in most of the states, so Government of India recommendation is, we have to for the prophylaxis of anemia, we have to give 60 milligram of elemental iron per day, along with folic acid 500 microgram per day, and which has to be continued till term, and it has to be administered at least for minimum of 180 days. And then we have treatment, like if the patient hemoglobin is less than 11, then the same tablet 60 milligram per day can be given twice a day and not more than that. And that we have to check, because initially some tablets were coming 100 milligram elemental iron also per day. So we have to give only 60 milligram elemental iron per day twice a day if we have to treat the anemia. And if anemia is severe, then it is better to refer the patient to a higher center, and then comes the role of parenteral anemia, parenteral iron therapy. And in the postpartum period, again we have to give the patient 60 milligram of elemental iron per day along with folic acid, which has to be continued for at least 6 months postpartum. So what about oral iron therapy? We know it is cheap and easy to administer, usually does not have any hypersensitivity reaction, but the main and most important problem with oral iron therapy is GI intolerance, poor absorption because of so many factors that we have discussed, and variable absorption rates because of some dietary factors, and if she has underlying inflammation. So oral iron therapy is usually insufficient to replenish the stores. So then there are various salts or preparations which have been prepared, but the most common is this ferrous sulfate and ferrous fumarate are the most common salts which we use in most of the iron preparations. So but when we are telling the patient to take oral iron therapy, we have to counsel them that there are some side effects which she may have, like constipation, bloating, epigastric pain. So we have to counsel the patient according to this. So how we have to instruct her, or what we have to tell her, that most important is like when to take the iron tablets. It should not be taken with the meals. She should take at least 2 hours before her next meal, or 2 to 3 hours after her option of iron solutions also. So how to check the compliance? We can ask some leading questions to the patient, like what is the color of your stools, are you having some gastritis or constipation like of symptoms. And if you really want to check, because in the village areas and in the primary health centers, so sometimes we can tell them to bring the return empty blisters packs, so just to check whether she is taking iron tablets or not, because tolerability and this side effect is a big issue in most of the iron preparations. So these are the iron preparations we have discussed. So we have to check, see, we don't have to see the salt, we have to see how much elemental iron one particular preparation is giving. So the dose is 60 milligram of elemental iron, which is once a day for prophylaxis and twice a day for treatment. So there is no point of overloading patient with iron tablets, like like you can see that this Otrin which is available in our hospital also. So this tablet, it is already containing 100 milligram of elemental iron. So this tablet if we are giving twice a day, so it will only cause side effects, because the studies have shown that it does not add to the better absorption of iron tablets. So these are small things which we have to understand and see when we are prescribing iron to the patients. So because we have this lot of studies now being done on hepcidin, because they show that when we are giving any particular iron to the patient, so if we are giving more than 60 milligram of elemental iron, so the hepcidin, it gets blocked for next 24 hours. So next absorption will start only after 24 hours, 12 to 24 hours. So if we are overloading the patient with excessive iron, so it will add only to side effects, not to the absorption level. So this we have to take care. So again, this is one study where they have compared that whether alternate day therapy or daily therapy produced same results. So this also showed that alternate day therapy can give us same rise in hemoglobin as compared to per day single dose preparations. So that this we need to understand when we are giving iron to these patients. So that are the points which we have to understand or take care while we are prescribing oral iron therapy to these patients. So the patient does not respond, or we see that patient is a candidate for parenteral iron therapy. So which patient we will switch over to parenteral iron therapy? If we have given oral iron therapy and she is not responding, and if she is not tolerating, or if the patient is in advanced pregnancy, like already she is 32 weeks pregnancy or beyond that, and her hemoglobin is less than 7, or so, then we don't have much time to see the trial of and to give the trial of oral iron. So these are the patients we can directly recruit for parenteral iron therapy. Or if patient is suffering from severe anemia, like hemoglobin is less than 7, and then patient with chronic renal disease, or those who are on erythropoietin therapy. So those are the patient where patient with renal disease and on erythropoietin therapy, they will not respond to oral iron therapy. They have to be given parenteral iron therapy. So what are the contraindication? If patient has some iron overload condition, so this is important. This is the reason why we get to check the iron stores when we are giving parenteral iron therapy. So we need to see what are the iron stores, because if patient's hemoglobin is 9 and we have not calculated that whether it's because of iron deficiency anemia or it is thalassemia, because thalassemia will already have heavy iron loads. So we should not overload iron with iron these patients. So we have to confirm the diagnosis. So if she has some hypersensitivity to IV iron, so sometimes we have to see that. But nowadays we have very good iron preparations available where the hypersensitivity issue is not there. Then we avoid giving any iron therapy in the first trimester of pregnancy. If patient is suffering from any type of active infection in the body, or if she has some acute or chronic hepatic dysfunction, then again we have to see if her transaminase levels are high, so we may hold on for a few days. So the prerequisites before giving or before recruiting a patient for parenteral therapy, that first we have to confirm the diagnosis, adequate supervision, because sometimes she may have some anaphylactic reaction, especially the first dose. Usually what we are following, we also give the first dose has to be given in the hospital setting where everything should be available to manage if there is anaphylactic reaction. So when we are preparing the patient for parenteral iron therapy, the oral iron has to be stopped at least 24 hours prior to therapy to avoid any reactions. So sensitivity testing, again it was initially recommended, but nowadays we have safe iron preparations, iron sucrose and ferricarboxymaltose, so which are sensitivity testing is not recommended for these. But when patient is being given this parenteral iron therapy, again we have to look for reactions while she is being given, for any chest pain, chills and rigors, hypotension, dyspnea. So these patients, these symptoms we have to check especially when we are giving the first dose. So how much iron to be transfused, how to calculate the dose? So this is the standard age-old formula which we all are following, as Ganzoni's formula. So we see what is the target hemoglobin. Like in our country, in our patient, we take target hemoglobin of 14. So if our hemoglobin is 7, like we see the difference, 14 minus 7 multiplied by 2.4, and then pre-pregnancy body weight. Plus this is the to treat anemia, and then we have to replenish the stores also. So for that we add 1000 milligrams. So this is a standard formula which we calculate to calculate the iron, how much iron has to be transfused. So once we have calculated the deficit, like we have calculated that she needs 1800 milligram of elemental iron, so then how to administer? So we have two types of iron preparations, intramuscular and intravenous. Intramuscular was initially initially they were famous, but nowadays we have very safe intravenous iron preparations. So we are usually not giving intramuscular iron. So mainly we will discuss this iron sucrose and ferric carboxymaltose. And then one important thing is iron dextran is the only iron preparation which can be given both intramuscularly also and intravenously also. So 20-30 years back this was main iron preparation which was being given, but the problem was because it has the dextran component which is responsible for severe anaphylactic reactions. So that is the reason this has been stopped and this has been replaced by other iron preparations. The advantage of iron dextran was that one, it can be given both intramuscular and intravenous, and the other advantage was the total dose infusion. The whole, like we have calculated, if we have calculated 1800 milligram, the whole deficit can be given at one point. But because of anaphylactic reactions, we have now switched over to safer preparations, this iron sucrose and carboxymaltose, and there is ferromaxidol. So these preparations are not available in India. So we will mainly discuss sucrose and carboxymaltose. So but in some primary health setting, maybe these IV injections are not available. So intramuscular injections are still being given in our country. So, but these patients are more again are at risk of anaphylaxis. Sometimes they have joint pains, skin discoloration at the site of injection, and she may have some itching, fever or headache or malaise. These are the vague complaints which can happen after giving IM injections. So for this skin discoloration, it was described that it can be given by Z technique, like given in this picture, that you can mobilize the skin. So there is a Z type of track is made. So when the iron goes inside, so the discoloration, it does not come to the skin level. But again we have shifted to now intravenous iron preparations. So if we see sucrose and carboxymaltose and iron dextran, so these are the main differences given in this table. So what is why we have shifted to iron sucrose and carboxymaltose? Because of these anaphylactic reactions. And mainly iron sucrose and carboxymaltose can be given IV. So if we have to differentiate between these two, iron sucrose is one injection where we can give maximum 300 milligram at one time, which can be repeated after 2 to 3 days, but maximum dose is 600 milligram per week. But the carboxymaltose, here the advantage is like we can give 1000 milligram of carboxymaltose over 15 to 20 minutes, and usually patient, the whole dose is covered in 1 or 2 injections only. So but the disadvantage of iron sucrose, why we are switching over slowly to carboxymaltose, because in the iron sucrose there is a problem, because we cannot give 600 milligram more than 600 milligram per week. So patient will require multiple visits, and there is some slight risk of thrombophlebitis also. So as compared to this carboxymaltose is better and safer, but there has been some reports of hypophosphatemia and high blood pressure. So basically these injections, they need monitoring. So first dose we give in the hospital setting, and this iron sucrose again, it has to be given slowly over 1 hour, as compared to carboxymaltose where higher dose can be given just in a span of 15 to 20 minutes. So this is our study which was done here, where we have compared these two drugs, carboxymaltose and iron sucrose. So iron sucrose, the main problem is that we can't give higher doses. So what we saw that FCM, it causes rapid rise in hemoglobin level, because the stores are replenished in more rapidly. So early build-up of iron stores. So it is well tolerated with minimal side effect, and the most important benefit to the patient, that she will require less number of hospital visits, less number of doses, complete dose is given maximum in 2 visits. So the patient compliance is better with this. So once we have calculated the dose, we have given the iron injections, and now how we have to check the response to iron therapy. The earliest response which we can see after giving any iron therapy, we can see reticulocyte count, which will increase in next 5 to 7 days only, or patient will see improvement in symptoms, better appetite, and when we can order her hemoglobin, so roughly it is 0.8 to 1 gram per deciliter per week is the rise. So we can tell patient to come back after 2 weeks with the hemoglobin, so we can see whether she is responding or not. So if there is no improvement in 3 to 4 weeks, then again we have to check that where we went wrong. Maybe the diagnosis of anemia was wrong. So again we have to re-evaluate the patient. So, and when we are giving iron therapy, it is very important, like we have given the iron, but again we have to give them folic acid and B12 also along with this, because if we are not giving them folic acid after giving injectable iron, so she will come back after 3-4 weeks, hemoglobin will not improve and she will develop macrocytic anemia, so which we will discuss in next slides. So we have to replace these patients, give with this folic acid and B12 when we are giving injectable iron therapies. So what are the indications of blood transfusion? Usually we avoid in pregnancy to give any blood transfusion. There are specific indications when we see the patient if she is in need of blood transfusion. If hemoglobin is like, if the period of gestation is less than 36 weeks and hemoglobin is less than 5, so up more than 5 we can very well, because we have time, we can give them parenteral iron therapy, which is considered safe. And if the hemoglobin is between 5 to 7 and she is presenting with congestive cardiac failure or some infection, or she has some underlying heart disease, because if patient is suffering from heart disease also, so they are the most dangerous cases where even smallest amount of blood loss or smallest amount of drop in hemoglobin can cause severe complications. So those are the patients we have to replace them with blood. So then if the pregnancy is more than 36 weeks, then we take cutoff of 6, because here she is near term, she may deliver any time, so we take the cutoff of 6 because we don't have much time before her delivery to replace the store with parenteral iron therapy. And then again one more indication of blood transfusion in pregnancy, like if she comes with acute antepartum hemorrhage or acute hemorrhage and the hemoglobin drops to less than 6 grams. So these are the patients where may think of giving blood transfusions. Or if the patient is in labor, like hemoglobin less than 7, so again these are patients are at risk of going into congestive cardiac failure in the immediate postpartum period. So if a patient with anemia, she comes in labor, like her hemoglobin is 6-7 grams, she has come in labor, so what all things we have to monitor? Patient should be kept in proper position with oxygen, because she is at risk of CCF. We have to keep the blood ready, because these are the patients who are at more risk of postpartum hemorrhage also. So we have to take care of analgesia, antibiotics, strict asepsis, and we have to see the signs of pulmonary edema, and we should not overload these patients with IV fluids. Second stage can be cut short with using forceps and strict asepsis, and third stage, active management of third stage labor is indicated in these patients, again with the because they are at risk of congestive cardiac failure and puerperal postpartum hemorrhage. So then after delivery, postpartum anemia, again the recommendation is same, 60 mg of elemental iron with 500 microgram of folic acid, which has to be administered at least for 6 months of postpartum period. So the doses are same for the oral iron, and if patient is not tolerating oral iron, if she has some malabsorption syndrome or if she has anemia is very severe, so sometimes what we do, if the hemoglobin is less than 7, so moderate to severe anemia, so what we do, we give them 1 dose of parenteral iron therapy in postpartum period also, and then we discharge them and we advise them to take folic acid. So in the postpartum period, again we have to take care that patient see for any the signs of failure, cardiac failure. We have to give them adequate antibiotics just to control so that they don't have any infections, because these patients are at risk of puerperal sepsis. So adequate antibiotic cover is indicated in these patients. We have to take care of their contraception according to their wish. So we have to give them all the options, and we have to advise them and tell them what is the importance of taking these micronutrients in the lactation period also, because they can have all these complications which we have discussed earlier. So then now few words about the megaloblastic anemia. Iron deficiency anemia we have discussed, but if we are not replacing them with folic acid and B12 deficiency also, they develop megaloblastic anemia. So WHO recommends again 400 microgram of folic acid for at least 3 months, and Government of India again in our country we also follow the same. We give 500 microgram of folic acid for at least 12 weeks of pregnancy. So, and if the patient has previous history of neural tube defects or the parent have neural tube defects, so these are the other indication where we give this much of folic acid to these patients, because this is basically because to control the neural tube defects. So the dietary requirement is increased of both folic acid and B12 in pregnancy and lactation. So we need to replenish these requirements. So how will we diagnose? These are megaloblastic anemia is not that common, as we have discussed iron deficiency anemia. So the patients, they usually present late, or usually we diagnose when the patient has anemia and she is not responding to iron therapy. This is one important indicator which tells us that she may have some underlying other micronutrient deficiency. And sometimes patient can present with anorexia, vomiting, GI symptoms, on neurological symptoms like numbness, paresthesias, weakness. So these are the symptoms of megaloblastic anemia, and she will have on examination pallor, glossitis and hepatosplenomegaly also. So what are the why it is important, like patient, if there is deficiency, the baby will have, fetus may have neural tube defects and malformations, prematurity, IUGR, and mother can also suffer from abortions, preeclampsia and abruption. So how do we diagnose? That initially we discussed that we go by the RBC indices. If MCV is more than 100 and MCH is more than 33, so these are the cutoffs by which we diagnose that she is suffering from megaloblastic anemia. And sometimes what happens, these patients, they suffer from pancytopenia also. So like their other counts also become low, and the reti count is also low because of ineffective erythropoiesis, because even if she has sufficient iron stores, the erythropoiesis is not happening because we are not supplying with folic acid and B12 deficiency. So LDH is again one marker, it is raised because of these in this anemia. So this is a blood picture, patient will have megaloblastic picture, and we get these cobalamin level and folate level, which are usually not available everywhere. Just we see the peripheral blood picture. If she has macrocytes, then we replace, but if we have the facility, then we can get these cobalamin levels and folate levels. And this homocysteine is again, it is for research setting, it is increased if the patient is suffering from folate and vitamin B12 deficiency, so these levels are increased. So what the preparation, how we have to treat folic acid, we have discussed that we have to give 500 microgram per day for treatment, and cyanocobalamin is available, which is if the patient has from B12 deficiency. So these are the various injections, this Vitcofol and Alderwit, these are the commonly available injections, and these are the injections which have both, they have folic acid also and they have cyanocobalamin also. So we can give these injections on weekly or alternate day, followed by monthly, and then some patients, they require even lifelong therapy if they have chronic deficiency of these micronutrients. So treatment is like the prophylaxis is 500 microgram, but if we have documented that she has folic acid deficiency, then the dose is 5 milligram per day, which has to be continued for at least 4 weeks after the delivery. And we have to supplement the patient with all the three things: iron, folic acid and B12. So B12 deficiency, for the dose we give this hydroxycobalamin, we give 1000 microgram. It is given either twice weekly or 3 times a week, initially for 2 weeks, then followed by monthly, which usually sometimes continues for life also, because these are the patients, they have chronically, they are the patient, they actually suffer from malabsorption syndromes, so they have repeated deficiencies, so they need to be replaced again and again. So here transfusion is also not the initial answer, it is only when the patient is suffering from severe anemia or she has some acute blood loss. So how will we see the response to therapy? Again we have discussed that initial thing what we can see is the reticulocyte count, which improves in the next 5 to 7 days, and LDH will decrease as we are replacing the micronutrient and hematopoiesis is happening, and then hemoglobin improvement we can see after 2 to 3 weeks. And the peripheral smear is one important thing, so it takes around maybe 6 to 8 weeks, it will come to normal. So this is also one important indicator to see response to iron therapy. So this is about the oral cyanocobalamin, which is available in some studies. They have studied that whether this oral B12 is same efficacy as compared to intramuscular, because normally we give intramuscular injections of B12, but there are some studies which are showing that the oral B12 is as equal to injectable also. But for us, we are giving injectable only in patients who have documented deficiency of B12 and folic acid. So then coming to the national programs, we have discussed in this lecture that all the recommendations which we are following in our country and WHO, which are almost same. So what are this government is doing, we have this Anemia Mukt Bharat, or under the National Health Mission. It is called Intensified National Iron Plus Initiative. So what are the targets? See, if we are treating only pregnant women, that will not solve the purpose. In our country, we have to see at different stages, starting from the children, adolescents, and all the women in reproductive age group. So just by treating anemia in pregnancy, we cannot tackle this problem of anemia in our country. So there are the different stages where we have to treat the iron deficiency and iron deficiency anemia. So what are they bringing? They are saying that it is 6 into 6 strategies. Like there we have 6 beneficiaries, 6 strategies by 6 interventions and 6 institutional mechanisms. So it is a multi-pronged approach to treat anemia in our country. So beneficiaries are children, adolescent girls and boys, women of reproductive age group, and then we have pregnant and lactating women. So these are the important beneficiaries where we have to address, we have to to manage this problem of anemia in our country. And then various programs are being this started, like prophylactic iron folic acid supplementation, deworming, that we have discussed, that other communications and testing of anemia to give the facility of hemoglobin checking at the primary health centers. So these are the programs which are being done. And then we have institutional mechanism just to have the better control that the treatment is being given to each and every eligible beneficiary. So just to conclude, that the recommendation which we have seen, that in the pregnancy it is 400 milligram of albendazole which we have to give all the patients. And again, if we see in our country, there are primary, secondary and tertiary level of centers. So the treatment of anemia will be according to severity of anemia. The mild anemia can be treated at primary health centers by giving oral iron tablets, but if she has severe anemia, moderate to severe anemia, and if the patient is not responding in 6 to 8 weeks, it is better to shift the patient to a higher center, because that will be the candidate for parenteral iron therapy. So this is just a small case which we had. It is just to emphasize that how we have to diagnose and treat anemia. This patient, she came to us with severe anemia, 30 weeks of pregnancy. She had not taken any folic acid tablets in the first trimester, and she could not take any oral iron tablets also because she had total intolerance. So when we reviewed her history, she had these generalized weakness, dizziness, body aches and syncopal attacks. So at 29 weeks she had again one syncopal attack. So she was diagnosed to have severe anemia, hemoglobin of 5 grams, and then she was given 3 blood transfusion, and then she came to us. So we just reviewed her history, and then she gave one baby of previous this IUD where baby had neural tube defects. So this emphasizes that she had chronically megaloblastic anemia, chronically folic acid and B12 deficiency she was suffering from. So she had all the signs of anemia like pallor and glossitis, aphthous ulcer also she had. So she had this physiological murmur also. So when we reviewed her this investigations, her lowest hemoglobin was 5, which had now come to 6.8 as she had received 3 blood transfusions. So her TLC was also on lower side, and then when she came to us, her TLC was 2560, which was again less, and platelets were also less. So actually she presented as a picture of pancytopenia. And then her peripheral smear again shows macrocytes and target cells. So it was basically different sizes of cells, so with the diagnosis of dimorphic anemia. So then we wanted to diagnose like what type of anemia she is having. So when we got all the investigations done, see her iron, ferritin, everything was high. So now LDH was also high. So how we were going to treat her? So we decided that as our iron stores are sufficient, which were actually because of recently received blood transfusions, so there was no role of giving iron at this point. So we started her on B12 injections, 1000 micrograms daily for 7 days, because she was having acute deficiency. So then we repeated her hemoglobin after 10-12 days. So what happened? The TLC improved, hemoglobin improved, but now the picture of peripheral smear shifted to microcytic. So because all the parameters were high because of recent blood transfusion, so actually she had dimorphic anemia. So then we gave her FCM injections. So then finally her hemoglobin improved and she had uneventful delivery. So this patient with hemoglobin of 5 we could manage without giving any blood transfusion. So this just emphasizes how to investigate and stepwise approach to a patient with anemia, because our main target is to treat every woman in our country to have not suffering from anemia and to reduce the blood transfusion as much as possible. So our country belongs to high prevalence area. Definitely oral iron is the first line of therapy, but there is no point of overloading these patients with more than 100 to 120 milligram of elemental iron. So all the patients should receive iron and folic acid prophylaxis in pregnancy. IV iron therapy, now we have very safe preparation, so we should have definitely low threshold to manage these patients with moderate to severe anemia. And as we have discussed in this case, complete stepwise workup and diagnosis is must for initiating iron therapy. Thank you. कौन सा स्टडी 60 अभी तुम जाओ, बंद कर दिया, वॉल्यूम बंद कर दो.